Hello, thank you for allowing us to share our study. My name is Danny Lammers, and I will be presenting our data on the use of the reverse shock index multiplied by Glasgow Coma Scale as a prospective predictor for mortality in pediatric trauma. We have no disclosures other than that the views expressed here are those of the authors and do not reflect the official policy of the Army or US government. Pediatric Adjusted Shock Index, or SEPA score, has demonstrated the ability to prospectively identify children at the highest risk for early mortality. Our group previously demonstrated that the addition of neurologic status to shock index has shown promise as a reliable triage tool in both adult and pediatric military trauma populations. To date, these tools have not been studied in civilian pediatric trauma patients. The study sought to assess the utility of combining SEPA with GCS, termed RSIG from here on out, for predicting early trauma-related mortality in civilian pediatric trauma populations. We performed a retrospective review of the 2017 Pediatric TQIP database. All pediatric patients with injury severity scores greater than 15 were included in the study. Both SEPA and RSIG values were calculated and compared. Optimal cutoff values were defined using receiver-operator characteristic curve analyses. The primary outcome of this study was to assess and compare each scoring system for their predictive mortality capabilities. 10,389 pediatric patients with demographic data as seen here were included in the study. The overall mortality was 9.3%. 32.2% of patients displayed an elevated SEPA score, while only 27.5% of patients sustained a positive RSIG score. RSIG was found to be superior to SEPA as a predictor for in-hospital mortality, with values of 0.854 versus 0.628 on AUROC analyses. Using our newly derived RSIG cutoff values, we found that RSIG outperformed SEPA for all metrics tested. Despite the pediatric trauma found in military environments differing drastically than its civilian counterparts, we sought to compare our recent results with our previously published results on pediatric military-related injuries. We found that based on the databases we assessed, RSIG proved superior in all metrics tested for civilian injuries as opposed to military injuries. In conclusion, we feel that including the neurological status of a patient with their presenting SEPA score, mortality screening and triage capabilities in pediatric trauma can be significantly improved. Although the retrospective nature of this study limits the conclusions we can make, we feel strongly that future work to optimize these findings should be sought to improve upon the pre-hospital and early resuscitative stages of pediatric trauma. Thank you.